textbook if you care to refer to them. We thought with antifungal drugs, learning objectives are generally the same for the antibiotic unit as it is for the today's unit. So when we talk about fungal pathogens, there are millions of species of fungi, but in animals and humans specifically, we've evolved to really have a number of defense mechanisms against getting infected by pathologic fungal infections. We have a number of host defenses around, say, body temperature and immune system. So fungal infections are not going to be typically, a long-term problem for immunocompetent patients. Immunocompromised patients, though, are going to be susceptible, particularly those with advanced HIV disease, cancer, transplant. And then the other issue is when antibiotic therapy, especially broad-spectrum antibiotic therapy, causes an imbalance of your flora. So in those cases, also, we'll see people being prone to, colonized fungal pathogens because of profit. How you get infected? Often, especially for systemic infections, fungi will enter the body as spores through the respiratory tract. Fungi are kind of these shape-shifting organisms that can take the form of spores or, over time can mature into more complex cell forms. So, with those different forms that they consume, they may have different levels of pathogenicity. This is kind of a hierarchy of the fungal organisms. The broadest category are molds and yeasts. And as you can see, the various different families underneath them. I'll highlight just a few that are really that we don't have to worry about. Types of infections range from superficial to systemic. You can get superficial infections affecting the skin, hair, and nails. Tinea pedis is very common presentation, which is athlete's foot. This is self-managed. We talked a little bit about this in your derm unit. Tinea capitis causes scalp ringworm, and then onychomycosis, which is a male dermatophyte. That is a little trickier because it often requires much longer course of therapy than most other infections. Mucocutaneous, of course, are your very common infections of oral candidiasis or thrush, or vaginal candidiasis, affecting the mucous membrane in the body. Subcutaneous infections can affect the connective tissue and muscle, and then you get your systemic infections of the urinary tract, respiratory tract, and the bloodstream. We also have a risk around central nervous system infections from cryptococci. In particular, these bugs are very notable for their ability to hide in macrophages and then enter the body and then proceed to enter into the CNS, causing meningitis. So, of course, a much more potentially severe infection. Of the pathogens, again, just a couple to highlight. Candida albicans. I like this phrase. It's the mono-human companion fungus. So think of all of us having a friend, a fungal friend, Candida albicans. It colonizes basically all of us in here. What we get concerned about is when it overgrows in the setting of immunocompromise. That is because, well, for one, it latches on, it survives all extremes of the very acidic pH of the GI tract to the more alkaline pH of the vagina. It can survive a wide range of body temperatures as well, and it resists recognition by human immune defenses. So when Candida overgrows, we really do need to address it very often pharmacologically, either topically or systemically. Aspergillus, this is a nasty bug and causes pneumonia, sinusitis, and brain abscesses. Typically, though, immunosuppressed patients are going to be the most prone to this, and Aspergillus can be resistant to many antifungal drugs. And then Cryptococcus, the aforementioned infection that can lead to bloodstream, CNS, and pneumonia. They will enter often via inhalation, and as they colonize the lungs for a long time before then being activated in the setting of immune suppression. So these are some of the bugs that will, fungal bugs that will come up from time to time as we fungal drugs. Fungi kind of represents a interesting space in the overall kingdom of life, I guess. Bacterial cells, which we're familiar with from our discussion so far, they contain a cell wall. The main component of these is the peptidoglycans in the bacterial cell wall. Right, that term may be familiar to you when we talk about the vancomycin mechanism, right? Targeting that peptidoglycan in the cell wall. But they have a cholesterol-based cell membrane, which is similar to what humans have, right? And then bacterial cells do not have a defined nucleus; they're considered prokaryotes, whereas fungal and human cells are eukaryotes. They have a encapsulated nucleus with the genetic material. Now, how fungal cells differ? Two key things. One is that their cell wall is primarily composed of a chemical called chitin. It's C-H-I-T-I-N, it's pronounced chitin. That is a key component of the fungal cell wall, and their cell membranes are ergosterol-based instead of cholesterol-based. Right, so those two things are the key differentiators between bacterial, human, and fungal cells. And as such, pharmacologically, a lot of the drugs we'll talk about target the ergosterol cell membrane and the chitin cell wall. That's really how they will be selected for fungal cells. So the fungal cell membrane agents include the polyenes, azoles. I love that term, azoles, and alloamines. The fungal cell wall targeting agents are quinopyrin. And then we have other drugs that look at protein synthesis and cell division. All right, so ergosterol is again a component of the fungal cell membrane, whereas cholesterol is the mammalian cell membrane. And as you see, they are actually very similar in structure. Cholesterol, as you recall from our cholesterol cardiovascular unit, for this very familiar four-ring structure. Ergosterol differs only in a couple of areas here. This double bond here is reduced in cholesterol. There's another double bond here that's reduced. So it's very similar, but again, it's distinct enough that pharmacologically we can target ergosterol and have it spare, at least to some degree, cholesterol. The drugs that work that target this include the polyenes, amphotericin and nystatin, and the largest group, which are the azole inhibitors. We'll start with amphotericin B. We talked about this drug last semester in the context of drug-induced renal injury, because this is one of the most notoriously nephrotoxic drugs there is. It is formulated in one of a couple of different versions. There's your conventional amphotericin B, but then it's also available in a number of different kind of modified formulations, either the Abelset, which is a lipid complex, or the liposomal amphotericin B, which basically takes a lipid bubble and puts it around the drug. What the lipid complex and liposomal versions do is, if you recall from last semester, I'm sure you don't, that's okay. They protect the kidney from amphotericin B-induced kidney injury. As such, they are more expensive, of course. And we typically, in the hospital setting, will reserve those patients with higher risk of kidney injury or whatever. For the most part, healthy patients with conventional amphotericin B, if we hydrate them appropriately, can avoid the worst of the nephrotoxic effects. Therapeutically, these are broad spectrum agents for severe systemic fungal infections. They're given by IV only. Correction, they can also be given as like bladder irrigations. You may see that for severe UTIs, but generally speaking, they're IV drugs. We use it for, again, your worst case scenario, the cryptococcus meningitis, aspergillosis. If we have a cancer patient with neutropenia coming in with fever, you might decide to blast them with antibiotic, broad spectrum, Anfo-B, and an antiviral, because it's a febrile origin. We're trying to cover everything. So you'll see amphotericin B used empirically in those patients. And then we'll talk about protozoal infections a little bit. Certain parasitic infections, leishmaniasis and amoebic encephalitis, also respond to Anfo-B. Again, we call it amphoterrible for the reason is a lot of toxicities associated, diffusion effects, chills, fever, headache. Basically, we treat with aspirin. Remember meperidine, this is an opioid drug. We use this for rigors. It may be helpful for some of the chills you get from amphotericin as well. The other use of meperidine, which you should know, is for rigors associated with like post-op surgery patients. Renal effects, again, key toxicity can reduce your glomerular filtration rates, leads to bumps in BU and creatinine as well as a drop in potassium. We manage it with fluid hydration, and you can give your higher risk patients the more expensive lipid-based formulations, the Avocet and Biosyn. These are reversible effects, so when you discontinue, you should see a return to baseline. Other side effects include both bone marrow suppression, liver failure, arrhythmias, and sometimes when you have a really bad infection that may require, say, a week or more therapy, what some centers will do is start out with amphotericin B for induction, maybe for the first couple of days, and then step down to a less toxic azole antifungal for continuing treatment. But really, amphotericin B, we think of it as our big gun for severe fungal infections. All right, similarly, is nystatin. Nystatin you may actually be familiar with in terms of the topicals. One of the, you see certain over-the-counter preparations for cutaneous fungal infections, creams, ointments, powder, etc. But also for less severe vaginal or thrush cases of candidiasis. Nystatin is not absorbed orally, so if you are given, really we're using it mostly for topical and irrigation type approaches. Again, really, Candida is the cutaneous Candida infections are where it's at here. And because it's not absorbed systemically, you don't get much in terms of side effects or drug interactions. But it's in the same therapeutic or chemical class as amphotericin B. Okay, and then really the other kind of major group of antifungals, there's lots of others, miscellaneous ones we'll get to, but the ones that you will see and use in practice the most. These are the azoles. Azoles work, again, by blocking ergosterol synthesis. It does so by inhibiting the enzymes in fungi that happen to be P450 enzymes that are involved in ergosterol synthesis. If you recall, really one of the main purposes of the enzymes is in terms of cholesterol synthesis, cholesterol processing, and turning vitamin D in the diet into cholesterol, androgens, estrogens, progestins. So P450 is involved in all of that processing. Just the same thing basically occurs in fungi. But now we're dealing with ergosterol instead of cholesterol. But what you don't kind of get away from is the fact that there is some overlap between fungal CYP450s and human CYP450s. So drug interactions from azoles are common. They're broken into two groups: your first generation agents, fluconazole, itraconazole, and ketoconazole. Those are going to be mostly for Candida and some of your milder infections. When you get to the second generation, posaconazole, voriconazole, isofluconazonium, which is a prodrug, isofluconazole, and acetaconazole, those second generation agents are going to be for your more severe aspergillus and streptococcus infections. And then there's a bunch of topicals. Again, these are for your dermatophytes, onychomycosis, and then there's a handful of them for, in case of myconazole, the vaginal Candida infections. So for vaginal infections, really quick, we have oral, which is the most common regimen, is with 1 dose difluconazole. Okay, 150 milligram PO times 1, right? High rates of vaginal candidiasis from that. You can use kind of the over-the-counter approach, like your monostat, either vaginal creams or suppositories. And that usually there's a 3-day monostat, a 7-day monostat, happy. And that would be the other approach for vaginal candidiasis, and there are over-the-counter versions for that. So really, as PAs, most likely we're going to be dealing with vaginal candidiasis, and really the 1 dose fluconazole will be muscle memory pretty quickly for you guys. All right, there are systemic agents for systemic infections. And again, the second generation agents are going to be for your tougher aspergillus infections. Oral agents are well absorbed. In the case of fluconazole, for example, 100% bioavailability when going from IV to oral, and they have wide distribution. So gets into the central nervous system, gets into fluconazole, penetrates the lungs, obviously urinary tract. And they're well tolerated, generally speaking, mild GI upset, skin rash. Vori does have some association with some visual disturbances, and itraconazole is associated with cardiac arrhythmias. But the key class of effects for azoles in general are P450 inhibition. And it's not a feature, it's not a bug, it's a feature, because basically that's how they work. They're P450 inhibitors in the fungus. Likewise, they do the same in humans. Fluconazole is implicated at a much lower rate than the others. And as such, fluconazole is really safe with drug interactions, but many of the other ones will have interactions with statins and warfarin and CDMS, etc. Questions on azoles? And probably all this lecture, those are the ones that end up using the most. Alamines, Lactin, and Lamisil. These are another group of drugs that work to block ergosterol synthesis. This time is through an enzyme called squalene oxidase. And that can be used topically for superficial dermatophytes, Lamisil, again, athlete's foot, ringworm, great for that. And then for onychomycosis, which are male-led fungal infections, Think of these as kind of similar to osteomyelitis when we talk about antibiotics. Because of really a smaller degree of circulation that reaches deep into the nails, it requires a longer course of therapy. Really, the other reason for this, which kind of goes against that osteomyelitis parallel, but I still like to use it, is that the drugs are fungostatic in the nail bed. So really what you're doing is waiting for that, uninfected nail to come and grow out, as opposed to, the infected nail, the infection spreading to the nail. So, really onychomycosis, you can count on, at least 6 weeks, and usually up to 12 weeks of treatment, regardless of which drug we're using. All right, next group, echinocandins, IV medications. We're going to reserve these for the severe fungal infections, caspofungin, microfungin, and antivirofungin. They inhibit the cell wall by blocking production of beta-1,3-glucan. There are some resistant candida strains that will respond to this agent. But again, some of the other tougher fungal infections, systemic fungal infections, can be used as well for these drugs. They're generally well tolerated. You're going to see some T elevations, depletion reactions, and some immune reaction. Leukocytosine 5-XT. This kind of has one of these chemotherapy mechanisms that we talked about earlier in the oncology unit. But basically, this is incorporated into the fungal RNA and causes chain interruption and other sorts of errors in protein synthesis and transcription and such. This is selected for fungal cells because the 5-FC is converted to 5-FU only by fungi and not by humans. So 5-FC is a prodrug, requires activation to 5-FU, which we know is a cytotoxic chemotherapy agent, and that 5-FU can then be incorporated into fungal cells. That because it's only activated by fungal cells, you do not get human hosts getting that activation. Anyway, we use it for cryptococcus meningitis. It's given only as a adjunct to amphotericin B because monotherapy develops very quickly if you use it by itself. And the toxicities are only going to be present because certain GI flora that live in the GI tract will activate 5-FC to 5-FU, and then you get some absorption there, leading to some of the critical chemotherapy side effects you get from 5-FU. Brisiopelvin, mostly for historic interest. Basically, this is an older antifungal that disrupts microtubule function, inhibits cell division. So this is a fungostatic agent, active against dermatophytes, actually not for candida, but other tibial type infections. This is fungostatic, so you will see longer courses of treatment. Distributes into skin, hair, and nails, so your onychomycosis will respond to those. And really the key thing here is that it's teratogenic to avoid pregnancy. This does have some pediatric safety data, so you'll maybe from time to time use this in kids, but really this is been widely supplanted by lasers. And a couple other topicals, cyclopyrox or Loprox with the nail lacquer. That's a formulation I've seen the most of it for nail bed infections. Requires 4 weeks of treatment minimum, and then from lactate to Mactin, which is for activating to the dermatophytes as a cream powder with 4 weeks. brings is your antifungal shield. Next is my favorite content on parasites. Must be alive. So here we're dealing with protozoa, which are your unicellular eukaryotes, all right, that can cause GI infections and waterborne infections like amoeba, and giardia. You can also get extraintestinal infections, plasmodium, toxoplasma, and trichomonas. Trichomonas can be sexually transmitted. Plasmodium you can get from mosquitoes. And then helminths or worms are classified as either intestinal or extraintestinal nematodes, trematodes, and cystids, which take worms, etc. Here again, you're dealing with like oral fecal transmission, dirty water, food poisoning in the worst case scenarios. Really, you don't get this like respiratory or physical contact, except in the case of sexual transmission, some trichomonas. When we talk about any parasitics, chemically speaking, there's your nitromidazoles. One of these drugs should be familiar to you, metronidazole. It's also tinidazole in that chemical class. Immunicides can be luminal, meaning they work in the lumen of the intestine, right? For local, when I say local, they work as it's transiting through the GI tract, they will exert any parasitic effects there. But then there's also more systemic immunicides. Antimalarials, malaria is a whole category unto itself, or briefly as well. And then drugs for common infections and like parasites like head lice. All right, so sites of action, if this is a cell, here, antifungals, there might be, just 2 or 3 targets like cell wall, cell membrane, DNA, RNA, but the antiparasitic drugs kind of are a mixed bag. They can affect ion channels, like here, chloride and sodium, calcium. But then also there are drugs that work on DNA, on various other metabolic processes, and pharmacopoeia on cell membrane. So a bit of a mixed bag. Really, I kind of go through this stuff more superficially because of kind of just the random nature of the pharmacology. But I'll highlight kind of what's important as we go through it. These are by and large relatively rare conditions, fortunately, especially in societies with clean air and water and not a lot of oral fecal transmission, etc. But you might get, for example, travel medicine for those of you who travel, for example, to less developed countries or tropical countries where mosquito-borne diseases are common. So, for some of your patients that may travel and that sort of thing. So it's important that we have this stuff. Start with the metronidazoles. These are metronidazole flagyl, tinidazole tindamet. So we call it flagyl. It can be given orally and IV for anaerobic infections, but they also have a role for certain parasitic infections from amoeba, giardia, and trichomonas. Treatment courses for these conditions range from 1 to 5 days. For example, trichomonas has a single day regimen where you give like 2,000 milligrams of metronidazole, either all once or separately by an hour or so, or there's a 3-day course of metronidazole for trichomonas. But some of these other conditions can only go up to 5 days. But basically, they attack organisms, infected tissues, for example, the intestines. They kill off the amoeba there. cross-reactive damage to the DNA. And you'll recall, especially with metronosols, that cause a metallic-taste in the mouth and a disulfide reaction, which of course is a flushing reaction you get from alcohol intake. So you should advise your patients not to drink they're on these medications. Tinidazole is a little bit more specific for these parasitic infections. Metronidazole, of course, you can see for bacterial infections as well. Next group are the luminal fungicides. These are for food and waterborne infections that cause infection of the GI tract and intestine. They include nitazoxanide, iodoquinol, and clomicin. They all kind of have different mechanisms, but the key thing that kind of ties this group of drugs together is that they do not have much in the way of systemic absorption. They stay in the GI tract and then exert their effects in the GI lumen of the small intestine and large intestine. So as they transit in the GI tract, they exert their effects more locally as they transit. You don't get much in the way of systemic absorption. And there, for patients with GI related diarrhea illness. There are patients that may have a concurrent infection with a more systemic bug. In those cases, we would give the luminal immunoside with what we call a tissue immunoside like metronidazole. That works more systemic. Metronidazole will have its systemic effects, the luminal drugs will work. And then we get to malaria. Like I said, it's kind of its own group. It is caused by a organism called or group family of organisms Plasmodium, and they're often mosquito-borne illnesses. The antimalarials can be categorized as either tissue antimalarials, in the case of primaquine, which works in the liver to inhibit multiplication of Plasmodium, or in the bloodstream, such as hydroxychloroquine and quinine. So these are the quinolone antimalarials. They include quinine, chloroquine, benzophen, and hydroxychloroquine. You may recall from the pandemic that hydroxychloroquine was something of a big deal. Why on hydroxychloroquine? Well, dummy. It works. Malaria, it is not an antiviral. So let's kind of put that in its context. For those of us who knew better, this whole hydroxychloroquine and ivermectin, which I cover in this lecture as well, it was a mess. And the other issue is that it's a toxic drug. It has all sorts of issues. So why is it something that doesn't work in place? I don't know. Those were some crazy times of pandemic. You'll tell your kids about it. Really reflect on how okay. So anyway, these agents can interfere with hemoglobin digestion. Basically, the malaria, the Plasmodium has this very specific life cycle where it digests. Part of it is where it digests hemoglobin for energy that the quinolone agents can interfere with. There's a few specific things here. Quinine is kind of the prototype agent. This is an alkaloid that comes from a plant called the cinchona bark. If you drink tonic water from mixed drinks, it contains natural quinine there. And the toxicity profile from quinine, think of it as what's called synchronism. That includes tinnitus, ringing of the ears, GI, nausea, headaches, flushing, and visual disturbances. Then everything else is kind of chemically derived or related there. Primaquine is helpful for liver reservoirs. reservoirs of Plasmodium vivax and Kamale, and it's associated with hemolytic anemia. Chloroquine really was one of the first widely used antimalarials, and if you look at malaria guidelines, really chloroquine is generally your first line agent. Mefloquine is an agent reserved for certain chloroquine. It's also used in malaria, but also has some benefits for autoimmune disease like SLE, lupus, and rheumatoid arthritis. It's associated with retinopathy, cardiomyopathy, and QT prolongation, which is why we don't just give it really anything for all cases. Again, we're going very superficially here. I'm not going to actually for a lot of the weeds, but synchronism and quinine, I think, is worth knowing. It's kind of a characteristic effect that's been recognized for many years. And then chloroquine is the key drug in malaria guidelines, so that's usually the start. Other antimalarials, as we've kind of progressed from the quinine derivatives, chlorardum, which is a combination of inhibitor and lumefantrine. This works by a couple of different mechanisms, inhibiting adenosine triphosphatase and inhibiting the formation of beta hematine. So basically, they combine with two different mechanisms to inhibit nucleic acid protein synthesis in the plasmodium bug, associated with palpitations, headache, fevers, chills, and anorexia. Overcome for hormonal is branded as Malarone. It's used for treatment and prophylaxis. So for people traveling to endemic regions, we may give Malarone as prophylactic. And here we're dealing with inhibiting mitochondrial electron transport and inhibiting a couple of enzymes that educated reductase in C synthase. So group by anti-helminths is again dealing with parasitic worms, roundworms, fruits, and tapeworms. And the results we come here on benzimidazoles, ivermectins, and prazoquinone. Benzimidazoles include two agents, albendazole and bendazole. And basically, in the worms, they bind to a protein called beta tubulin, and that inhibits the fermentation of the tubular environment that's involved in microtubule production. So basically, it will limit the availability to intake glucose from its energy source and leads to the polarization effect. So this is useful for pinworms, trichinosis, or tapeworms. It's given as 1 to 3 dose regimens. If you ever have to treat someone with it, you should take a high-fat meal on top of my absorption. If it's a systemic infection, but if it's a luminal infection, meaning that you don't necessarily want it to be absorbed, then the best approach is actually to take it out of the empty stomach, so that it can absorb as much and it can work into the You know, these are short regimens, but they can have some mild concentration. Ivermectin, again, another your Joe Rogan special on remedies for COVID. This is really a broad spectrum anti-helmintic for scabies and lice. It's used for worm infections and anorex as well. Basically, it paralyzes the muscles of helminths by increasing chloride permeability, and basically the neuromuscular production there is going to be disrupted. Usually given as a single dose for scabies and lice. pneumococcal infections. And then parental is a over-the-counter treatment for hookworms and pinworms in the intestinal tract. Again, causes paralysis, peaks and nematodes, leading to chronic and side effects from chronic epilepsy, largely diarrhea. Here, it's often given as either a single regimen, two-dose regimen, or polypharmacy to one or two other drugs. Parental, if you ever happen to have patients with a schistoma and a treatment-toad cestode infection, this can be one of the drugs of choice. It basically, again, targets calcium for treating paralysis of the flukes and tapeworms. And this is, again, short course, 1 to 2 days, but maybe longer for a condition of neurosis. Again, a shorter course is a well-tolerated multi-clinical with GI side effects. And then finally, for ectoparasites, your lice and mites. Basically, you can have surveillance for these in a school setting. And if, they recognize that. Fortunately, we do have effective topical treatments. For methrin, when given as a topical cream or shampoo, will basically kill the head lice. Likewise, for spinosad and trova, that's given as a topical treatment and then saw. Questions on parasites? I see. Great. Antimicrobacterial drugs, I think is a lot more interesting. Here we're dealing with tuberculosis and also leprosy and related conditions. Mycobacteria are bacteria, but they differ from your typical gram-negative, gram-positive dichotomy in a number of important ways. We consider these what's called acid-fast bacteria. So they do not get decolorized with our typical gram stains. So you're not able to classify this either gram-positive or gram-negative. Acid-fast. But they're hard to detect for one, and they can kind of colonize and live in the body for a long period of time, and be very insidious. So we really have to do our best to recognize that. Obviously, healthcare providers are screening for TB, right, through the open skin test, and more frequently nowadays, blood testing. The other challenge with this is that they have a lot of innate resistance. Remember we talked about innate resistance. These are characteristics of the drug itself that makes it resistant to antibacterial treatment. And in the case of mycobacteria, they have a very thick cell wall. So that, renders it very difficult to penetrate with drugs, and really requires lots of patients, for treatment. These are long treatment regimens, and they often are very smart in terms of resistance. So basically, all treatment regimens for tuberculosis is going to require multiple drugs, which is why I do this. And tuberculosis is responsible for pulmonary disease and, in the worst case scenario, meningitis. And leprosy, skin and peripheral nervous system disease. And then your MAC, Mycobacterium avium intracellulare, is seen in AIDS, HIV disease with this particular opportunistic infection. but otherwise it is extremely immunocompromised. All right, so how we approach TB. If it's prophylaxis, meaning, there is, like a positive screen, but they're not active with TB, they might just be in a dormant phase. You can give monotherapy for 9 months or, a combination therapy. If it is active TB and you're able to, get susceptibility testing, we will be using combination treatment. Not one, not two, but up to 3 to 4 drugs, up to 9 months. Very often, this will require directly observed therapy for especially patients who are not as reliable, meaning what healthcare provider witnesses the administration, but this could be very labor intensive, but our state, Montgomery County Health Department, they have programs with this directly observed because of the international population and high tuberculosis risk. And then with HIV, because they're on antiretrovirals, we can talk about this week, there's also other drug interaction between there as well. This is what our algorithm for TB looks like. Again, I'm not necessarily saying that you need to know the specifics around the regimens, but the idea here is duration of therapy and the need. Clinical factors like application, that's like that's the fact that there's snare, there's training, there's again, duration can be minimum of 6 up to 12 months. Really good. Perfect. So our antimicrobial drug, the first line agents, INH, isoniazid, Gabapentin, furosemide, and your lithiumycin derivatives. And then your second line agents, including betaquilline, aminoglycosides, streptomycin, amikacin, fluoroquinolones actually have a role. Moxicillin, I would say some regimens is actually considered the first line. But citral and legal can be used as well. And then for leprosy, and that they use dapsone as an inhibitor. All right, isoniazid INH, the mainstay for active and latent TB. It inhibits the synthesis of alcoholic acid. Again, that mycobacterial cell walls are unique in that it's different from regular bacterial cell walls. So this mycolic acid target is appropriate for antinizing for TB. This is metabolized by a phase 2 reaction called acetylation. And acetylation actually happens to be subject to genetic polymorphisms. So we have fast acetylators and slow acetylators. That is determined by your genetics. Slow acetylators will not metabolize the drug as fast and then could be more likely to develop toxicity. Whereas fast acetylators clear the drug faster and have a lower incidence of side effects. So that genetic polymorphism is driving the again, these are long-term regimens, 6 months, 9 months. So side effects are going to be relevant for patients with liver disease and alcohol use disorder, older patients that are at risk for hepatitis. They could cause some neuropathies, peripheral neuropathies. INH actually reduces a pyridoxine vitamin B6 deficiency. So we have to supplement with that pyridoxine to help offset nerve toxicity and less likely you'll see seizures and blood out. There are some people with the inhibition causes drug interactions, and resistance to INH is low in US born patients. Internationally, may be more of an issue, but again, it can develop when therapies are not combined with polypharmacy or with thinking. So you have to be very aware of that risk. Second, INH specific drug is Pharm. Again, use of part of a triple quadruple regimen. And this again targets the mycobacterial cell wall. Calling here is imatin or galactic. It undergoes renal and hepatic elimination. The key one issue here is optic neuritis. So for ethambutol, especially again, if you're going to be on it for months and months and months, the recommendation is that patients, as they're receiving treatment, get assessed for their visual acuity. Because if you get color blindness, particularly red-green color blindness, and other issues around optic neuritis. So we have to monitor the visual effects as they are on this drug with the personalized effect. You can also get some peripheral neuropathy as well. The resistance is around 2% in American born patients from the enzyme that catalyzes that around infection. Third, our first line agents, pyrazinamide, inhibits fatty acid synthesis for the cell membrane. There is a step where pyrazinamide gets converted to pyrazinoic acid. And that is the active drug that inhibits fatty acid synthesis. It is widely distributed, mostly metabolized in the liver. It gets some leucemia, hepatitis, and GI upset. And again, the enzyme that converts pyrazinamide to pyrazinoic acid can be mutated, causing resistance. And finally, rifamycin, mutant. This works broadly against gram-positives and gram-negatives as well as tuberculosis. But again, this can be in the setting of tuberculosis, one of our untreatable complications. Inhibits DNA transcription around nucleotides, and another one where root resistance can rapidly develop in use of if it's one thing to remember about the phantom, actually two. One is that it's a very, very potent CNS P450 inducer. Drug interactions galore. Really one of the model drugs when we talk about CYP induction, rifampin is at the very top of the list. Second thing to remember is that it discolors your urine with its bright red. That can be allergic to patients, and just let them know it's in everyone. That's our first line TB drugs. Any questions? Rifampicin is used for its longer half-life, so you can take less frequently. We talked about the red orange coloration for Betaphyline or Sorturo, it's a newer drug, approved December 2012. When I say newer, really between the first line agents, isoniazid, really for 50, 60 years, that was the only intent. Quinolones came along, and then this newer agent. Basically, this is still considered second line agent for multi-drug resistant TB. Works by blocking the proton pump ATP synthase. I think it's a black box on this drug. And then Russia. And these are some of the other second line TB agents. I cover them really quickly because you should know them. Familiar to you, moxifloxacin, levofloxacin, and Cipro, also fluoroquinolones. They work by inhibiting topoisomerase, which is the enzyme that uncoils DNA, double-stranded DNA. In the setting of TB, or specifically, mycobacteria, tuberculosis, moxifloxacin is the most active of the three. But like some of the other mycobacteria subtypes, you might see Cipro have more activity than the others, or Levo, or whatever. But specifically for tuberculosis, moxifloxacin is the most active. And again, you'll see regimens with moxi, rifampin, isoniazid, and so moxifloxacin in a lot of cases is used even in first line. So linezolid. This is used for MRSA, right? It also for TB can be helpful for some multi-drug resistant tuberculosis. And again, because these are prolonged courses, you might see some side effects for linezolid you wouldn't otherwise see. In this case, bone marrow suppression. And then aminoglycosides. Aminoglycosides are the ones we use for bacterial infections, gentamicin, tobramycin, amikacin. Remember, they are concentration dependent, specifically with data use to know that. But for TB, they are helpful for really more the ones we use, streptomycin, which we can talk about for bacterial, and then amikacin, which of course we did cover. These are still iron IV, okay, very poor systemic absorption orally. So, you know, if we do resort to we will have to give it iron patients. And then the key effects here still are nephrotoxicity. That's tuberculosis. For leprosy, you have dapsone. It also is the key drug for pneumocystis jirovecii pneumonia, which you see in AIDS patients. We use it for prophylaxis of people. Toxoplasma as well. But dapsone is a self-owned drug that inhibits folic acid synthesis. Saprophylamide is a self-owned, slightly different chemical. Because GI upset was in neuropathies, optic neuritis, and it's also been associated with lupus syndrome. It's contraindicated in the patients that have the G6 phosphate dehydrogenase deficiency. That's a genetic condition that puts some patients at risk for genetic anemia and exposed to certain things. I just have these limited availability agents, etazimine and thalidomide. Unlikely to encounter this unless you work closely with patients that have leprosy and travel medicine, etc. Etazimine is only available through limited manufacturing program. We put it on to bacterial DNA to long half-life. Thalidomide, we talked about this in the oncology unit. It has a lot of different cellular mechanisms, but really we use it as kind of leprosy as well. As an object of anti-antigen. And then move into some cases. Start with the first one, a 36-year-old woman. She's developed vaginal candidiasis. What did I say on the options for vaginal candidiasis? Well, fluconazole. What's the regimen there?
One
One dose, 150 milligrams times. What if she was self-managed? Monostatic, and that would be vaginal cream or the LMS suppositories, and that is the 3-day regimen. Here's a nice statin formula approach you can do as well, and you can actually give other stuff. Okay, so it's like really mostly vaginal candidiasis, which is like cover azoles, or cortisol. Please. She's 56. She has amoebic colitis. She started on metronidazole, but an infectious disease consultant recommends adding fibromycin to her regimen. So for amoebic colitis, there are two different approaches. One is luminol drugs that work locally in the GI tract, and the systemic drugs that will have more tissue penetration because they're absorbed. So fibromycin is one of these drugs where you give orally, it will affect the parasite that's in the intestinal lumen, which is why we'll give it a conjunction, which is called tissue amoebicide, that's where two different drugs come to play. Really good. Some of these are really going to be pretty superficial in terms of them. I want you to know metronidazole is all fragile as an antibiotic. I have some familiarity with the spectrum, but as far as some of these less common fungal infections, just be able to justify the disease. Right? And then our third case, we have 35-year-old hospital employee gets a routine tuberculous skin test reaction, 18 20. So you guys know how this works, right? You get a antigen that's kind of intradermal, like right in the skin, that's administered, and then within, say, 72 hours or so, you have someone read it, and the idea is that if there is a kind of a quelling, a wheel type reaction that's measurable, it will be a positive test. So tuberculous skin test on this collection. So in this case, 18 millimeters. That's a significant reaction. And the patient, the employee, the person, started on prophylactic INH, 300 milligrams a day in 4 months. So here, again, we are looking at prophylactic treatment. They're not necessarily symptomatic, and that's not going to necessarily be the case for your tuberculosis. They may just have inactive TB, and in those cases, we would need to prophylax. You can go with INH, or you can go with polypharmacy. The advantage of using multiple drugs for prophylaxis is that you might have to give it as long. So, and I say not as long, I think like 3 months still. So, let's kind of be aware of how we approach prophylaxis versus treatment. Key things with TB treatment is polypharmacy, duration of treatment, and then for the key first-line drugs, the highlights of sort of counter side effects, neuropathy, optic neuritis, bandage on behavioral changes, those, kind of unique side effects for each of those. We talked about the acetylation and adolescent. So, tuberculosis is kind of this thing where not tremendously common. You'll see enough of it that, and therapy is long enough that it's going to kind of impact the patient's daily lives. So It's good to have at least a decent comfort level with that condition. Okay, questions? Hopefully next week y'all won't be as worn out, overwhelmed. Get into you know, I have a little time. I could literally go into the antibiotic contact. It's very. We'll save that for next week.
Thank you.
All right.
Thank you.
Good luck.